Welcome to this foundational module on one of the most common yet nuanced areas in aesthetic medicine, the periorbital region. When we discuss crow's feet, or lateral canthal lines, it's easy to think of them simply as wrinkles to be filled or frozen. However, as an aesthetic nurse, your expertise lies in understanding that these lines are not static features. Effective and, more importantly, safe treatment depends entirely on your ability to analyze how these lines form during movement, how various muscle groups interact, and how these patterns vary significantly from one patient to the next. In the periorbital region, wrinkle patterns are a direct clinical reflection of the underlying activity of the orbicularis oculi muscle and the patient's overall facial dynamics. In this session, we will move beyond simple observation and into a structured clinical analysis of dynamic versus static patterns, common movement classifications, and the multimodal treatment strategies required for optimal patient outcomes. To treat the eye area safely, we must first distinguish between dynamic and static patterns. Most crow's feet begin their life as purely dynamic lines. These are the fine, radiating lines that extend from the lateral corner of the eye specifically during facial expressions, most notably when a patient smiles or narrows their eyes in bright light. In these early stages, the skin typically appears smooth when the patient is at rest. However, we must educate our patients on the progression of these lines. Over time, the repetitive mechanical stress of muscle contraction, combined with the natural reduction in skin elasticity and collagen, causes these dynamic lines to etch into the dermis. They become static. As the condition progresses, you will notice the lines becoming deeper and more defined. You may even see textural changes extending into the lower eyelid. This distinction is the cornerstone of your treatment plan, because botulinum toxin, or Botox, is primarily designed to treat the dynamic component by relaxing the muscle. If a patient presents with deep static lines, Botox alone may not provide the blank slate appearance they expect. Recognizing this early allows you to manage patient expectations and introduce alternative or supportive approaches, such as skin boosters or resurfacing. One of the most important skills you will develop is pattern recognition. Crow's feet are not a one-size-fits-all correction. Let's break down the 4 primary patterns you will encounter in clinical practice. First, the radiating fan pattern. This is our most common presentation. You'll see lines spreading outward in a symmetrical, fan-like shape from the lateral canthus. This indicates a broad activation of the lateral orbicularis oculi. For these patients, your injection strategy should involve evenly distributed points across the entire lateral area to ensure a soft, natural relaxation. Next is the central dominant pattern. Here, the lines are more concentrated in a smaller, localized area right at the level of the lateral canthus. This suggests that the muscle contraction is strongest in one specific segment. Rather than a wide, shotgun approach to injections, these patients require more focused dosing within that active zone to be effective. The third pattern is the inferior extension. In this case, the lines extend significantly downward toward the upper cheek. This pattern is particularly important for safety, as it reflects a complex interaction between the orbicularis oculi and the cheek elevation muscles, like the zygomaticus. When treating this pattern, we must use extreme caution. If we inject too low or too deeply, we risk affecting the muscles that support the lower eyelid and cheek, which can lead to a heavy appearance or even an asymmetrical smile. Finally, always look for asymmetrical patterns. It is very common for one side of a patient's face to show more prominent lines, often due to natural anatomy or habitual sleeping positions and expressions. In these cases, you must move away from mirrored dosing. Your treatment must be individualized, perhaps 3 units on the left and 5 on the right, to achieve a balanced final result. We cannot look at the eyes in isolation. Crow's feet are inextricably linked to the mechanics of a smile. When a patient smiles, a chain reaction occurs. The orbicularis oculi contracts, the zygomaticus muscles elevate the cheeks, and the skin folds along natural tension lines. If we place Botox without considering this muscle interplay, the results can be clinically disappointing. For example, if we overfreeze the lateral eye but the cheek still elevates strongly, the skin has nowhere to go. This can cause bunching under the eyes or make the smile appear wooden or unbalanced. Furthermore, If we fail to treat the full extent of the active muscle, lines may persist in untreated regions, creating an effect where the top of the eye is smooth but the bottom crinkles unnaturally. This is why assessment must always, without exception, include active movement. Never plan your injections on a static face. Your clinical assessment is the most important part of the appointment. Start by asking your patient to give you a big natural smile, the kind that reaches their eyes. Watch closely. Where do the lines start? Where do they end? Are they deep creases or fine ripples? Your goal is to determine which specific muscle fibers are the most active and where your product will be most effective. This prevents the two biggest pitfalls in periorbital work: undertreating, which leads to persistent lines, and overtreating, which leads to a loss of expression or complications like ptosis. A pattern-based approach allows for precise placement and better aesthetic balance. If you treat based only on how the patient looks while sitting still in your chair, you are essentially guessing where the muscle activity is. This increases the risk of creating asymmetry or missing the very regions that bother the patient the most during their daily life and social interactions. In the world of aesthetic nursing, if it isn't documented, it didn't happen, and more importantly, if it isn't documented correctly, you lose the ability to refine your technique for that patient. Your chart should reflect your dynamic findings. Instead of just writing crow's feet treated, include the pattern type, the muscle activity level, and your rationale. Before you ever pick up a syringe, run through your internal safety gate. Have you seen them smile? Have you checked for asymmetry? Does the patient understand that Botox won't erase a static line that has been there for 10 years? Only when these boxes are checked should you proceed. Finally, let's discuss how we select the right tool for the job. While Botox is our gold standard for dynamic lines caused by muscle contraction, it is not our only tool. When a patient presents with static lines or visible volume loss under the eye, we may consider dermal fillers. However, remember that fillers interact with deeper layers, such as fat pads and structural bone, rather than the muscle itself. Fillers in the lateral eye area carry higher risks, including irregular contours or, in rare cases, vascular complications. They should be used to provide support, not to fill a crow's foot line directly. For those fine, superficial crinkle lines or for patients with thin, dehydrated skin, skin boosters are an excellent choice. These are placed in the superficial dermal layer. They don't stop the muscle from moving, but they improve the skin's canvas by increasing hydration and collagen quality. The best results often come from combination therapy. We use Botox to address the muscle-driven wrinkles and skin boosters to improve the surface quality. This sequential conservative approach ensures that we are treating the anatomy at every level: muscle, dermis, and structure, safely and effectively.